atraumatic instability of the SC joint is very rare, and essentially it will clunk, and you will see it clunk as they go through range. And essentially, if you do some symptom modification, you'll be able to change it. If you haven't seen it, don't panic. But if somebody comes in who's in that adolescent group, that young group, still growing, again, remember, if there's no history of trauma, if they're lax or they've just got some definite overactivity in plexus sternocleicular mastoid, they're our job until proven otherwise. Hi, my name's Jo Gibson, and I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK, and I'm also a consultant in private practice. I just had a few technical hitches before. My computer wasn't playing at all, so apologies to anybody that's been waiting for me to start. Me and technology never get on that well, and it's definitely been one of those days, so apologies for that. Now, we had a week off last week. Basically, I had a day off and had some lecturing commitments, so I couldn't be here. Looking forward to seeing some familiar faces join us this evening, and some great questions, I'm sure, as ever. So hi to everybody that's joining us, and I promise I'll get to your questions at the end. And as I say, once again, real apologies if you've been hanging on waiting for this to start. I'm not quite sure what happened. All my passwords had gone, etc. Anyway, tonight I promised you a rehab example. So we've had quite a lot of weeks where we've been doing some detective work. I've been sharing some interesting cases and getting you to work out what you think they are. And I promise we'll be doing some more of those as we come over the next few weeks. But I just thought it'd be nice to return to a rehab example and talk about some of the challenges, some of the things we need to look out for, further to a question actually that came up a few weeks ago. So tonight what I thought we'd talk about is non-traumatic instability of the sternoclavicular joint. So somebody asked a question about this when we were talking about SC joint injuries and fractures in pediatric patients and young athletes. We talked about epiphyseal plate injuries, etc., etc. And one of the questions that we didn't really get to answer was about atraumatic instability. So I wasn't going to talk so much about the traumatic SC joint dislocations, purely because they require an awful lot of trauma. Generally, they're associated with other injuries as well. Very rare compared to other types of shoulder dislocations, account for less than 3% of all shoulder dislocations. However, these atraumatic sternoclavicular joint instabilities, whilst rare, can be a little bit of a challenge. And it's also a group that I think it's a fantastic example, really, of when we kind of need to know our outcomes, because actually when you look at the literature and how many of these patients do well, there's actually quite a spectrum in terms of what's out there. So thanks to all of you that are joining us. I'm not being rude, not saying hello or whatever else, but there's so many great people joining us. I'll be here all night if I say hi and catch up. We'll have to do an alternative coffee evening, I think, so I can catch up with you all. So atraumatic SC joint instability. So what do I mean by this? Well, let's say you get an 18-year-old who comes in, who's a little bit on the hypermobile spectrum. So we talk about hypermobility spectrum disorders now to encompass what we used to refer as joint hypermobility or benign joint hypermobility syndrome, or the hypermobility group of Ehlers-Danlos, where it just affects the musculoskeletal joints. If you look at some of the new classification systems with hypermobility, there's 20 subgroups of Ehlers-Danlos now, so definitely worth going to the hypermobility.org website for all the information about the new classification system. But let's say we get a typical stretchy 18-year-old. He's got excessive external rotation in neutral at his shoulders, both in neutral and abduction. So let's say he's got 100 degrees, so definitely lax at his shoulders. Scores a 4 out of 9 on the Baton hypermobility scale. Quite tall, quite slim. And for what can't give any particular mechanisms of onset, but notice when he started trying to throw things in the garden and play overhead sports with his mates, that he's getting this real clicking over the medial end of his clavicle, and it's really irritating him. It's associated with pain if he does anything above 90 degrees, and he gets this real clunk, and you can actually see the S joint subluxing as he goes through range. It's kind of almost worse on the eccentric phase than on the concentric phase of elevation. So what are the things that we need to think about in this particular group, and what is there out there to help guide our treatment? Well, I guess the first thing to say is it's always about that detective work and, if you like, really drilling down to any previous history of trauma. Certainly people who specialise in, who have a special interest in the sternoclavicular joint will use the Stanmore Triangle that's been used in glenohumeral joint instability and apply it to this group to basically inform decision making. And when you look at the Stanmore Triangle, essentially we have those three key groups. We have the traumatic, the polar type 1 group, who have structural injury as a result of trauma. You have a type 2, which is our non-traumatic but have structured injury generally of the capsule or a lax capsule. And then we have our type 3, which are referred to as a muscle patterning group. So basically abnormalities in how the muscle system are working result in instability of the affected joint. Now, clearly trauma or not is a really important thing in this cohort. Now, a couple of things that are just interesting for you to know. Those of you who've joined us for the talks about pediatric will know when we've talked about the epiphyseal plate in the clavicle, the medial one is one of the last to ossify and fuse, and actually doesn't fully ossify and fuse until between 23 and 25. So it's kind of the last one to go. Now, the reason that that's significant is if somebody has trauma, so it can be a blow to the side, it can be a direct blow, it can be a blow from the back, depending on the angle will depend which way potentially the SC joint goes. But let's say we've had a traumatic history. The reason I'm telling you about that is that actually in those patients under the age of 25, certainly the younger they are, more likely it is that they'll almost get like a fracture dislocation because they'll get an injury at that metaphyseal plate because it's the weakest part of the bone. So just something to be aware of. Now, you would think that those things will get picked up, but I've seen two guys who played rugby who had injuries where they took a major contact blow to the side. They ended up with a little bit of a lump and some medial pain, didn't think anything much about it, and then over a period of time the shoulder became more painful. They kind of noticed a change in the contour of their shoulder because it was relatively shortened, because essentially they'd had this metaphyseal plate injury, it had overlapped and it had healed in that shortened position, and then they'd started to develop problems. So clearly with this 18-year-old, it's very important I ask if he's had any previous history of trauma. Again, if they've actually had a clavicle fracture, even if it's in the mid-shaft of the clavicle and there's some shortening, again, there seems to be some link with shortening in the clavicle and a potentially increased risk of developing some instability in the AC joint. So asking about that history of trauma in the past is really important, and particularly in combination with age. Now, when we look at other things that can weaken that glenohumeral joint capsule such that somebody could actually develop instability, we actually see another cohort, older, middle-aged, menopausal ladies. I'm not sure where the menopause comes in, but certainly that middle age group that get some osteoarthritic changes in the joint, which again can then result in instability. Relatively rare, and generally it's less about instability, it's more about pain and a little bit of a lump, but just something to bear in mind. Now, when we look at the background to this young cohort, so let's go back to our patient. So he's come, no clear history of trauma. He's grown quite a lot recently. He's 18, he's stretchy, and he doesn't like doing anything overhead. And it's very obvious this SC joint's coming out forward. Now, what could cause that? There's some experts that suggest that as people go through a growth spurt and there are changes in the clavicle, because obviously it's not reached its full length yet, that there are some patients that because they have this kind of flattened shape of the clavicle, which doesn't distribute the force quite as well, that they're more likely to develop instability. Now, I think if we're honest, a lot of that's expert opinion. I'm not sure we've got convincing evidence to support it, but actually the case series out there are relatively small, so it's difficult to extrapolate that. There's no doubt if patients have a scoliosis associated with local glenohumeral joint laxity, then that does also seem to be a risk factor. And as I say, any of our hypermobile spectrum disorder groups or any of our connective tissue disorders in terms of our Ehlers-Danlos, those genetic phenotype type issues, then that could be relevant. Now, I've said this guy's coming out anteriorly. That's by far the most common with non-traumatic instability at the SC joint. Very, very, very rare and very few case series published of people who have posterior instability. Now, it's important to mention posterior instability. Some great comments coming in. I promise I'll come back to those. There's some Other very important things just about posterior instability, particularly if you think about those examples I gave you where somebody might have had a previous history of trauma where they've got shortening of the clavicle, somebody who's had a missed metaphyseal fracture, so arguably anybody who has trauma with some medial sternoclavicular joint signs who's under the age of 25, really we should get a CT because that's the most effective way of actually looking at these metaphyseal plate injuries. But there's some other things to look out for with a posterior dislocation and anybody who develops posterior instability, because obviously there's some very important things behind your clavicle. Namely, you've got your brachiocephalic, your subclavian vein, you've got your trachea, you've got your esophagus, you've got your carotid. There's some really quite important things there. So again, any kind of symptoms that are suggestive of maybe thoracic outlet type symptoms, if you've got swelling, aching, heaviness in the upper limb, they can actually get venous engorgement both in the arm and also in the face, might complain of headaches, but some other symptoms, tachypnea, so rapid breathing and stridor, that kind of high-pitched wheezing sign. And if those things are worse when they lie down with any history that might suggest posterior instability, things definitely to be aware of. The other warning signs are shortness of breath, dysphagia in terms of difficulty swallowing. Now, obviously, if somebody comes in after massive trauma and they've got some pain and element of injury there, any of those symptoms are obviously an emergency and need investigating quickly. But there are case series of people who've had previous trauma who then gradually develop more instability and then start to have some of those associated signs. So just something to be aware of. If you look at the traumatic posterior sternoclavicular joint dislocations, about 30% will have some of those symptoms. So not uncommon, as you can see. Now, back to our non-traumatic group. So our type 2s and our type 3s. So we've got the lax capsules and we've got the ones where the muscles are working too hard and pulling them out of joint. Now, interestingly, the bony architecture of the SC joint is actually quite unstable. Only about 50% of the bone's in contact. But the intra-articular disc and then the ligaments around it are what give it its stability. And interestingly, you'd get less arthritis in the SC joint than the AC joint. Now, is that because it's more stable or less? We don't really know. However, the disc is really important, and again, something to consider in your differential diagnosis. So with this guy, essentially, if we look at what the evidence suggests, there was a paper by Rockwood years ago looking at physiotherapy intervention for exactly this sort of cohort. So laxity, repeatable subluxation of the SC joint, but without a history of trauma. Now, they had a series of 68 patients, and out of those, 78% basically got to a stage where they got back to no limits with their activity and back to all the things they wanted to do lifestyle-wise without any major restrictions. Now, that sounds great, doesn't it? And you think, whoa, we're really successful in this population. However, when you drill down to the detail, actually, 90% of that cohort still had ongoing subluxation, and 21% of them still had some associated pain. Now, there's no doubt that quite a lot of the experts out there will say that actually, if it's not symptomatic and it's just clunking in and out, then we should decatastrophize that and say actually the shoulder can cope great, because actually, as if you remember what I said, that epiphysis doesn't fuse until around 25, there's still potential for the length of the clavicle to change, because often these patients present in late adolescence. 18 is the kind of most common age, but obviously there's a little bit of a spectrum around that. But what's interesting is if you look at those over 25, it goes away. So it's something that does seem to be self-limiting in most populations. Now, there's one other case series by Tunnicliffe and Alison Armstrong, who are based in Leicester. They presented this at BET in 2015. And basically, when they looked at this non-lax group, without any history of trauma, their success rate, interestingly, Jo, get your facts straight. In the lax group with no trauma, they had around 13 patients. So again, out of a series of 49, and basically 9 out of that 13 got better with rehabilitation. So again, a pretty good success rate. But interestingly, with them, those 9 patients, 8 of them were stable. So they did get rid of the subluxation. One of the patients had some ongoing minor symptomology relating to intermittent subluxation. And then there was quite a dropout in terms of people not following up. 2 patients had recurrence, but again, when they started their physio, then the symptoms went away again. So we've kind of got this spectrum that's a little bit difficult to kind of unravel in terms of, we've got Rockwood saying that actually we can get rid of symptoms, but patients might still have some subluxation. And then we've got the other end of the spectrum saying actually we can be successful in about 75-80% of people. So what we need to try and understand, well, what are the things that we can do to try and help these people get better? Well, I've talked about the ligaments, but what about the muscles? Because as physiotherapists, those are the things that we can really target. Now, in Tunnicliffe's series, they talked a lot about a common feature of patients with a real chin poke, real dominance of their sternocleidomastoid, and also pretty, tall teenagers with dreadful posture. And I know we all get excited about there is no perfect posture, but you all get the jet. I always think Shaggy from Scooby-Doo. And the bottom line is, if when we look at the muscle system and what's going to affect stability of the sternoclavicular joint, we've got some key considerations. We've got our sternocleidomastoid, obviously, attaching to the clavicle. We've got our pectoralis major, our sternal and clavicular fibers, and both those muscles are invested in the fascia that reinforces the ligaments around the SC joint. And then we've also got subclavius, again, obviously from the first rib to the clavicle, which again is invested in that fascia. And finally, the fascia from the cervical spine also invests around there. Now, if you look at our muscle patterning instability groups, or our 2-3s, so some laxity with some associated abnormal muscle recruitment, then what we commonly see is dominance of pectoralis major, particularly those sternal fibers. But I have seen both sternal and clavicular, and definitely some contribution of sternocleidomastoid. So if we're going to look at an approach to treatment, that's really helpful in terms of informing us with the things that we might want to do. And if I'm honest, when I look at my lax type 2s and my type 3 muscle patterners, my kind of approach to treatment is very, very similar. Essentially, in my rationale in my head is to promote the scapula doing its job properly, which is always getting the cuff and scapula to do their job together, but as ever using symptom modification to try and inform the exercise that's going to give best value for that patient. Now, the things that often tend to work are things like a wall squat with the ball behind them on the wall with a loop of TheraBand to get the posterior cuff working, because it obviously gives them some nice input both to their thoracic spine and the scapula as they're then recruiting through range. So that's something that I find works really well. If I'm honest, when I look at my approach and the things that give me best value, there's no doubt changing the lever arm, giving some resistance, promoting the scapula, the things that generally work from a symptom modification point of view. But in this cohort, it definitely seems to make a difference if you add in something that really emphasizes the cervical spine. So for me, that's generally just cervical neutral in conjunction with those exercises. And then whatever I get them to do, I'm kind of reinforcing those components. So I could get them in bridge over a ball rather than against a ball on the wall to achieve the same thing. And again, that's quite a nice way of bringing some specific strengthening in. Sometimes I'll get them the other way around, hugging a ball, and again, pushing up and out. Remember the kinetic chain. If we initiate our exercises with the kinetic chain, it just makes it easier to get that local system doing its job. But again, particularly in patients that are a little bit fearful of that clunking and a little bit apprehensive about moving, doing very dynamic movements can be a really nice way of overriding those compensations. But again, really reinforcing that link between the thorax, the cervical spine, and those posterior muscles to stop the dominance of those anterior ones. But as I say, in this case, I think what can be really important is really targeting the cervical spine. Now, my experience in these patients is generally, if you look again at the evidence, it will say on average it takes about 6 months for people to get the optimal outcome. And again, like most instability in the shoulder, 6 months is a good ballpark in terms of outcome. I expect them to be seeing a difference by 6 to 12 weeks, but it can take 6 months before they get back to where they want to get. But those kind of are the, if you like, the key principles of what I like to do. Now, there's one other important thing. Prof. Frostick, who I have been lucky to work with for years and years, who sadly is not with us anymore, he was always he always stressed the importance of never forgetting about the disc, because there are definitely patients come with painful clicking at the medial end of their sternoclavicular joint in this age group, often a bit more muscly or play sport, and actually you can't feel any subluxation. You can feel a clunk, and it's painful at the point it clunks, but actually it doesn't seem to actually sublux. Now, clearly, you want to be sure it's not going posteriorly, but in that situation, and particularly if somebody's doing any sort of sport where there's repeated kind of force with rotation, so like a tennis serve, or somebody who's had some repeated loading type history, just be aware of that disc, because you can actually get a complex tear in the middle of the disc, which will give you a painful click. But again, there should be something in the history that makes that useful. That can also be the sequelae of kind of trauma and falls that haven't been significant enough to cause a dislocation or cause a fracture, but actually have just done some local damage to the disc. Now, in that case, MR arthrogram can be hugely useful just to evaluate the disc and see if there is any damage. So remember, CT is really useful for your kind of traumas, and certainly anybody that you're querying whether there's an epiphyseal plate injury, but MR arthrogram is really useful for looking at the disc. If you've got anybody with any of those horrible, weird and wonderful symptoms we talked about, then actually CT angiogram can be really useful, because obviously you can look at those other structures as well. So guys, I know there's loads of questions, so I'm dying to get to those because there's all sorts of other things been coming in. So let's get on to the chat and let's see what you're all asking me tonight. So now, all sorts of great people here that I haven't seen for years and years. I shall give you personal messages on Facebook afterwards, I promise. So we have a question from Tim who says, does EDS or hypermobility syndrome improve with age? I've heard of some people who report their hypermobility gets worse with age. Is this unusual or common? If so, why would hypermobility get worse with age? So generally, if you're looking at, sorry, I'm just trying to get onto these other questions because there seems to be loads there. I'm so rubbish at this. So Tim, essentially, if you look at hypermobility, so joint hypermobility, benign hypermobility syndromes, then generally they do improve with age as we get a natural change in tissue stiffness. Now, in terms of managing symptoms, again, it tends to depend where you sit on that spectrum. So, as I say, if it's just musculoskeletal, it's just affecting musculoskeletal joints, then absolutely it tends to improve with age. And certainly if you follow up patients who have instability, like multidirectional instabilities, it used to be called, but basically have laxity in their glenohumeral joint and associated joints, again, they will improve over time as they get into their 30s because things stiffen up. Now, in terms of why would it get worse with age, I think that's a really good question. And I think, again, it's very much understanding those subgroups of hypermobility. It's perhaps something we should talk about on the Facebook Lives one evening, because as I said, with these new classification systems, they're actually describing 20 different subgroups of things like Ehlers-Danlos syndrome. So again, it's if there's a familial history, if it affects not just your musculoskeletal joints, all those things might impact that lifetime experience. But again, for more information about that, I definitely recommend going to that hypermobility.org website, because it's got tons of information about lifetime prevalence and the course of it and all the things that are out there, but importantly goes into that subclassification a little bit more. And I'll also post a useful article on there. So in terms of why it would get worse with age, I think it's very much dependent on the different types, and it's more common that actually symptoms improve as people stiffen up. So Nikki, can this happen in adolescents who lift weights and play overhead sports, not necessarily lax, and can it be non-symptomatic? Absolutely, Nikki, absolutely. Now, interestingly, in the non-lax, non-traumatic group that might play sport and get these episodes, it can be completely asymptomatic. And that, I love the fact that you've brought that up, because actually that's one of those situations where we really need to decatastrophize. People can actually have a subluxing SC joint and not have any major symptoms and not have any functional restriction, as long as the disc and some of those ligaments are intact. So as long as they've got some stability there, they seem to function very well. The intrinsic ligaments, the posterior and anterior sternoclavicular joint ligaments, seem to be the most important. So you can actually cut many of the others away and actually still cope. So you might just have some changes there. And again, it can relate to the length of the clavicle, but if it's not symptomatic, then we don't want to make a big drama about it. And as I say, the likelihood is it will just self-limit over time. So thank you very much for that question. Again, I would, in adolescence, again, I think because of this tentative interest in what happens to the clavicle as they're changing, and particularly if they've had growth spurts around the time they've started to become symptomatic, they've started to develop the subluxation, they're not symptomatic. It's just all about those things of optimizing, for want of a better word, the muscle system around their shoulder to prevent that dominance. Because again, as you know, particularly adolescents often like to do a bit of lats, a bit of pecs, and that might be the thing that just tips it over the edge. So for me, I wouldn't be making it all about having to get rid of it, but I would definitely be doing things to make sure their cuff, their scapula, those other things. So I've got perhaps better balanced activity, and that would include emphasizing the thoracic spine as well. So Nikki, great question. Thank you very much indeed. Now, I'm pretty sure there was a question early on, which I can't get to at the moment for some reason. Oh, God, everybody's here tonight. This is awesome. Some fantastic friends here joining me. It's lovely to see you all. I'm sorry I can't stop and have a chat. But hi, you all know who you are. I'm sure there was a question. Oh, here we go. I just about got on it then. I'm sure there was a question before that was saying about ankylosing spondylitis. Now, again, that's a great question, because again, if you've got some significant scoliosis, is the only thing that there's much published about in terms of increasing the risk of a sternoclavicular joint issue. But I guess arguably anybody who's got significant stiffness there with associated laxity and some of those other postural things that we talked about, then essentially that might be something to bear in mind. So guys, you're keeping me on my toes tonight. Sorry, I don't know why my computer hates me tonight. I don't know what's going on. I'm getting a bit paranoid. Right, there was another question there, I think saying, here we go. What SC joints? So physio, Femke, hi Femke, good to have you here. Which SC joints would you inject, if any? Oh, great question. So if you think of that age group, I talked about the menopausal ladies who present with a little bit of lump and swelling over their SC joints. Remember, we've done a podcast about sternoclavicular joint not instability before in terms of pain and swelling and symptoms. And I definitely would have a listen to that if you're interested in SC joints, because we talk about all the weird and wonderful things that can happen in the SC joint, because proportionately it's the site of some nasty pathologies. So if you get pain and swelling, you need to be vigilant and need to investigate it. However, if a middle-aged lady comes to you with a painful, swollen SC joint, it's probably osteoarthritis. You've got to rule out other things, but essentially some patients struggle with pain, and injection can be a really reasonable thing to do. Interestingly, if you look at these instability cohorts, and again, they've got pain experts. Graham Titherley Strong's written about this. There's a great paper by Sewell, Martet Schlager. They all would advocate injection as part of conservative management if patients are struggling to progress. However, I would say that it's not something we routinely use in our instability cohorts. So I think if you've got somebody who's got SC joint pain and swelling in an older cohort with symptoms consistent with osteoarthritis, injection is entirely reasonable. I would be reluctant to use it in my instability cohort, but that's just personal preference, as I say, because it is out there and published. Oh, Annette, sorry. Yes, you're absolutely right. So Annette says here, first signs of AS can sometimes be a swollen SC joint. Absolutely. There's some other things like psoriatic arthritis. 60 to 70% of patients can have swelling in their SC joint. Similarly, rheumatoid arthritis, about 30% have involvement of the SC joint. It's a funny old joint, but what I like about Annette's point in the swell, and we talked a lot more about this in the podcast that we were talking about pain and swelling as opposed to instability, which we're doing tonight. But again, I love that. If somebody comes with SC joint symptoms, you need to be asking more questions if they've got pain and swelling, because as I say, it's a sign of all sorts of weird and wonderful things. But I could go on for another hour talking about that, so maybe we'll revisit pain and swelling in the SC joint sometime soon. Now, as I say, the key thing about this evening was really talking about instability. And so what I hope I've done is really share with you some of the research that's out there in terms of, one, the outcomes. And I guess one of the messages I wanted to get out tonight is I never forget a guy coming to see me who was in his early 20s, who'd had a 5 or 6 year history of a subluxing sternoclavicular joint, wasn't causing him any pain, but psychologically it was messing with his head because it hadn't got better. And actually he had been told right from the outset that essentially it wasn't an issue, but for this guy it was an issue and he didn't understand. And so even though symptomatically it wasn't causing him huge issues, that kind of failure to if you like, addresses expectations from the outset and reassure him that his shoulder can function absolutely great, and the fact that he didn't have associated symptoms is quite an important message, because remember that Rockwood study that said people got back to doing everything they wanted, even if they had some ongoing subluxation. As I say, Tunnicliff's works a little bit more positive in that we can expect to reduce that subluxation in that lax non-traumatic group. In the non-lax, non-traumatic group, then our success rates aren't quite as good. And so again, it's always backing it up when patients don't respond to conservative management, always backing it up with appropriate investigation to see, have we got some involvement of the disc, and therefore surgery might be an option. And then obviously going down that surgical line. But remember, minimum of 6 months. Now, thank you to all those who answered the question about AS. Somebody, for those of you who are listening on the podcast, there was a question asking what AS is. It's ankylosing spondylitis, sorry. Lots of nice comments. Thank you very much. Just making sure. No, so there's no other questions there. Fantastic. So guys, I really hope you enjoyed that. I'm sorry about the technical hitches at the beginning. I'm a bit flustered this evening, but hopefully shared some good clinical things with you again. I will post a couple of those key articles on the Facebook page, so go there if you want to find those, and definitely worth having a read afterwards. As I say, physio-wise, there's a real limitation in terms of what's out there, and to be honest, we probably need to look back through our series and share our results, because I think applying some of those key principles I talked to you about, we have had some good success both resolving subluxation and symptoms. So guys, thanks for all the lovely comments. Thank you as ever for your questions. It makes it really fun. I think we might revisit painful swollen SC joints at some point. Next Monday, we're going to talk about differential diagnosis of something that came up on Twitter last week. Talk about lots of potential things that we need to consider. But as ever, guys, thanks for joining me for some more shoulder geeking. And I will look forward to seeing you all again very, very soon. Oh, I think we've got one last question. Marlene, SC joint issues is quite rare, or is that just my experience? Also, what is the basic symptoms involved in this? Elevation, end of range symptoms, etc. So the key thing, if this is relevant, is that you've got, sorry Marlene, just to it will be obvious, it is very rare. Atraumatic instability of the SC joint is very rare, and essentially it will clunk, and you will see it clunk as they go through range. And essentially, if you do some symptom modification, you'll be able to change it. If you haven't seen it, don't panic. But if somebody comes in who's in that adolescent group, that young group, still growing, again, remember, if there's no history of trauma, if they're lax, or they've just got some definite overactivity in plex and sternocleicular mastoid, they're our job until proven otherwise. So well done for sneaking that question at the end. Right, I really am going now, guys, because after my late start, we're even later. Thanks a million for joining me, and very much look forward to seeing you again next Monday for some more shoulder geeking. See you then. Bye-bye.